Education and Training Committee. On behalf of the Operating Room Global and the TORG Global Education and Training Committee, I'm delighted to welcome you to today's global webinar. We are pleased to have a truly multidisciplinary audience with us today, including surgeons, anesthesia providers, nurses, surgical technologists, educators, researchers, students, and healthcare leaders. We are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you're joining us from Africa, Europe, Asia, Middle East, or America, you are very welcome. We strongly encourage active participation throughout the session. Please use the chat box to introduce yourself, sharing your name, professional title, and country. And also post your questions and comments at any time during the presentation. Our moderation team will be actively monitoring the chat and will bring your questions forward during our Q&A session. For those joining a TORG session for the first time, the Operating Room Global is a multidisciplinary professional platform representing over 260,000 surgical and preoperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TORG brings together 42 healthcare disciplines and specialties currently and operates as a nonprofit and non-governmental organization founded in Nigeria in August 2015. Today, TORG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and preoperative care through education, research, advocacy, innovation, and capacity building, with a strong focus on safety, equity, and system strengthening. TORG is an internationally accredited continuing professional development provider, recognized by the CPD group, underscoring the quality and global relevance of our educational activities, and is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research, and Innovation, incorporated in Ireland, which leads our global agenda in education, research, innovation, and participation. Our affiliated journal, the Operating Room Journal, is an open access, peer-reviewed international journal inaugurated in May 2025, providing a platform for high-quality evidence that informs practice and policy worldwide. TORG is also proud to host its own institutional review board, officially registered with the U.S. Office for Human Research Protections, reinforcing our commitment to ethical, responsible, and globally credible research. TORG is driven by a volunteer-led leadership model powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We're actively engaged with global alliance, including the J4 Alliance, Intersurgeon, and are listed with the Union of International Associations and the Global Civil Society Database, reflecting our global accountability and reach. Once again, thanks everyone for joining us today. We sincerely appreciate your time and participation, and we hope that you enjoyed today's session.
Good evening to you all. Am I audible?
Yes, we can hear you perfectly.
Okay, my name is Pacific Shimwe from Rwanda, and I'm currently joining you as the presenter of our first speaker for today for this webinar. And I'm an anesthetist in Rwanda, and I'm currently serving as TORG committee member, TORG-ETH committee member, and it's my pleasure to present to you our first speaker for today. She is Professor Josephine Cody, and she's going to talk about human factors and teamwork in the operating room. Allow me to present to you our Professor Josephine Cody. Our professor is a seasoned healthcare education leader, certified surgical technologist, and has served as Senior Surgical Technology Program Director. She is a professor with over 14 years of experience in allied health education. She has dedicated her career in developing high-quality academic programs, mentoring future healthcare professionals, and advancing excellence in clinical education. Professor Cody has taught a wide range of fundamental and advanced courses, including medical terminology, microbiology, anatomy, physiology, and pathophysiology, and even surgical terminology. Her instructional approach blends academic rigor with real-world operating room experience, ensuring students are well prepared for both certification and clinical practice. As program director, Professor Cody has led program development, accreditation, compliance, faculty mentorship, and clinical partnership expansion. She is recognized for her strong leadership in curriculum design, student success initiative, and interdisciplinary collaboration, and operating oversight. Her work emphasizes professionalism, patient safety, teamwork, and workforce readiness. Currently, she is serving in Seattle, Washington. Professor Cody is known for her ability to blend education and industry, creating innovative learning experience such as interdisciplinary mock clinical event that shows collaborative patient care across allied healthcare discipline. Beyond academics, she is passionate about community engagement, women healthcare education, and mentorship. She also manages digital platform focused on menopause awareness and professional development, extending her impact beyond the classroom. Professor Cody, she holds a master's degree of education, bachelor's of science with minor in healthcare management. She completed 𝐶AAHEP accredited surgical technology training and is active member of the Association of Surgical Technologists. Her leadership style is grounded in integrity, service, and deep commitment to empowering students to succeed in fast-growing healthcare careers. We are delighted to welcome Professor Josephine William Cody to share her expertise with us today on human factors and teamwork in the operating room. Thank you, Professor Cody. The floor is yours. Thank you so much.
Thank you so much. And thank you all for having me today. I know it's different times in the world. Here in the United States where I am, Seattle, Washington, it's 10 a.m. And I have other guests that are here who have joined me there in different parts of the United States as well on their different time zones. So good morning, good afternoon, and good evening to you all. I have a slight cold, so please bear with me. Today, we're learning outside of the box, human factors and teamwork in the operating room. This is about the human side of surgery, not just skills, but behaviors and decisions and teamwork. We don't see it. We don't hear it, but something feels off. Is it the count, the closure, the patient? And in that moment, there are 5 seconds. 5 seconds to speak. 5 seconds to stay silent. That moment is not about technical skill. That moment is about human factors. The story I just told, it isn't rare. It's predictable. This is systemic. Up to 70 to 80% of adverse events are linked to communication and teamwork failures. 1 in 3 surgical interactions contain communications or communication breakdown. As we continue with this PowerPoint, what are human factors? We train for the hands, but do we train for the humans? Cognitive load, fatigue, hierarchy, assumptions, silence. Would you speak up? Who holds the power in the OR? Did you know that even highly skilled teams can fail when human factors break down? Yes. We teach procedures, skills. Yes. We teach steps. Yes. We teach policies. Yes. This is where learning outside the box becomes the solution, not creativity for the sake of innovation, but simulation, discomfort, reflection, rehearsal, because we do not rise to the occasion. We fall to our level of training. Here's the reality. The surgical technologist is not just passing instruments. We're not just there for a specific function. We are observers, anticipators, environmental scanners, safety advocates. And if we are not trained to act in those 5 seconds, the system fails. The responsibility shifts. Human factors cannot be eliminated. At the center of the OR, that's where you'll find us. Anticipators, not reactors. Guardians of sterility and flow. Human factor sensors. As anesthesiologists, human factors cannot be eliminated. As a surgeon, human factors cannot be eliminated. Circulating nurse, human factors cannot be eliminated. Silence is one of the most dangerous human factors in the operating room. Speaking up, clarifying assumptions, preventing silent errors, closed loop communication. Can you all hear that? Can you hear that? Absolutely nothing. We can't hear that. So as we move on into the operating room, into these human factors that we have to deal with, we are now looking at 3 reasons why we don't speak up. 1 second as my system catches up. So in the OR, hierarchy is necessary, but it is highly dangerous. Learning outside the box allows safe rehearsal of speaking up. Structure versus silence. Rules and change of command can unintentionally discourage voicing concerns. You've got authority gradients, power differences, doctor versus tech, senior versus junior, Those affect communication, psychological safety. Team members must feel safe to question or challenge decisions. In high-risk environments like surgery, hierarchy must exist, but teams must actively counter its negative effects so people feel safe to speak up and prevent errors. Simply put, good teamwork saves patients, but the fear of rank can cause mistakes. Mistakes in training prevent errors in real surgery. What this builds? It builds situational awareness, confidence, mutual respect, stronger teams, safer patients. This is the ROI of learning outside the box, return on investment. When people practice advocacy, they perform it under pressure. Humans are not machines, but we can design education that provides and prepares people to perform under pressure. Learning outside the box builds psychological safety, rehearses advocacy, normalizing speaking up, strengthens teamwork before a crisis. Now, it's not theory, but it is a design responsibility. Attention, educators, team leaders, especially in high stakes environments. Move beyond tradition, those task only training, and move beyond that. Instead, build safer, more human centered teams. Teach humans, not just tasks, train judgment, communication, confidence, and decision making, not just how to do the procedure. Design learning for reality. Prepare learners for distractions, pressure, hierarchy, and mistakes, the way real life actually works. Empower every voice. Create psychological safety so anyone can speak up to prevent harm, regardless of rank. Simply put, again, challenge traditional training models. Innovation improves safety and teamwork. The goal is to build thinking, speaking, adaptable professionals, not just technically competent ones, because safety depends on human behavior, not just skills. Speak. In every operating room around the world, there will be a moment where something feels off. And in that moment, there are 5 seconds. We cannot eliminate human factors, and we can prepare for them. We cannot move hierarchy, but we can rehearse courage. We cannot predict every complication, but we can train teams to respond. At the beginning of my presentation, I presented to you 5 seconds. 5 seconds to what? Say something. Because patient safety does not begin with incision. It begins with voice. Thank you for listening to my presentation. If anyone have any questions, I'm available to answer any questions that you might have.
Thank you so much,
But
Professor, for the insightful presentation. We're going to take questions at the end of both presentations. Dear Emmanuel is going to introduce our second guest speaker for.
And thank you to the Professor Cody for the insightful presentation on human factors and teamwork. It was a powerful reminder that what happens in the operating room isn't just about technical skill. It is about how we communicate, how we support one another, and how we function as a cohesive unit. Those human factors are often the first of defense in patient safety. Now, as we move to the second part of our webinar, we're going to take those foundations of safety and look at them through a clinical lens. We are shifting from the people in the room to the procedure on the table. Our next topic is critical for everyone, regardless of what they do or the specific role. We will be discussing on preventing common complications in surgery, in general surgery, practical safety strategies. Surgery by nature carries risk, but as we just learned, many risks can be mitigated or reduced. We are about to hear how we can apply evidence-based strategies to anticipate complications before they happen, ensuring that our patient not only survive surgery but recover without problem or preventable harm. To lead us through this important discussion, it is my absolute pleasure to introduce our second speaker, Dr. Nebiyou. Dr. Bayleyegn is a general surgeon and assistant professor of surgery at Jimma University Medical Center. He holds an MD, an MPH, and a Master of Science in Global Surgery and brings strong expertise in surgical safety, quality improvement, and system-based approaches to care. He is the chairperson of the Operating Room Global Ethiopia chapter, where he plays a key leadership role in advancing safe surgical practice, workforce development, and capacity building. His work is particularly focused on strengthening surgical systems and improving patient outcomes in resource-constrained and high-burden settings. Through his clinical practice, academic role, and global surgery engagement, Dr. Bayleyegn has contributed to initiatives that emphasize prevention of complications, practical safety strategies, and translation of evidence into everyday surgical care. We are delighted to welcome Dr. Nebiyou S. Bayleyegn to this session. Dr. Nebiyou, at the floor is yours. Thank you very much.
Thank you, Emmanuel, for the introduction, and thank you, Professor Cody, for your nice presentation. We took a lot of lessons from there. And I think my presentation as it entails on the complications in surgical care. It's a bit of like a huge book. So I would say in the eyes of Professor Cody, it could have been like a 30 or 20 slides, but mine is not that much. So I will just try to give my emphasis first to have some kind of patience and discuss issues with surgical complications. So I have no disclosure to make. We will start by the definition of surgical complications. It defined by Cleveland Lindo in 2004, which classifies a surgical complication into grades. They put it as any unintended adverse event or deviation from the normal recovery pathway after surgery, which is not usually as part of the planned procedure. So this could be like minor complications like surgical site infection, a minor one, and it can be up to the extent of major complications like organ failure or death. So when we see the global burden of surgical harm, To start with, there is a global buzzword which was introduced after the Lancet Commission for Global Surgery in 2015, which stated that 5 billion people globally has lack to access surgical care. That's the buzzword. And now with we find that as more than that size of the population has no access to surgical care. But still, when we see the burden of surgical harm, evidence showed that about 300 million surgeries are just done annually in the globe, and out of which complication rate reaches up to 15% and much higher in LMIs as compared to the high income countries. And the mortality rate is up to triple as compared to the high income settings. And this shows us a systemic gap which reflects a failure in the system, not a mere presence of an individual problem or in the provider care. So as 15% of these complications happens out of the 300 million patients. So these complications can range from minor infections up to mortality. But another statistics showed that annually an average of 4.2 million people dies after surgery every year. Within 30 days of the operation, and this accounts for 7.7% of all global deaths, including the infectious disease and other cancer mortalities and so on. So when we see in terms of the countries, there will be mortality of like 3.5 on average out of every 1,000 admissions over in low-income countries versus less than one of in high-income countries. So generally, to put in numbers, around 50 million adults experience post-operative complications each year. And these complications can reach up to 25% of inpatient surgeries globally, which is very high in organ failures and such other types of complications in low-income countries. And when we take the regional breakdown, so the high-income countries, for example, in the USA and Europe, annually about 70 million surgeries are taking place. So as you see, the complication rate is not that much. It is just at less than 2% range, but it is just about 10% in hospital mortality in low-income countries, and in sub-Saharan African country, there will be a 20% complication rate in every surgery, and all of which one patient could die due to anesthesia-related complications in the sub-Saharan African countries. So saying that this all complications happening, and also the global unmet need of the 5 billion people of lacking access to surgical care. To put in numbers, like in the latest report of the Lancet Global Surgery, around 160 million population has no access to essential surgical care, which is life-saving emergency care, including laparotomy and fixation for long bone fractures and cesarean section. So as we have stated earlier, surgical care, surgical disease represents 1/3 of the global disease burden, including the major or the named big infectious disease, TB, HIV, and malaria. So after this all statistics, why surgical complication matters? So this complications drives avoidable mortality and disability, long-term disability, and in turn, it can lead to erosion of trust in the healthcare system, and the financial toxicity as well as the disability is untold. As well, 50% of these complications are preventable with existing knowledge whenever, as Professor Cody stated, whenever human factors, teamwork, and situational awareness and other like leadership type of conditions are met. So apart from the statistics morality, when we see the ethical imperative of safe surgery or preventing complications, as it is put forward by the Hippocratic oaths, first, do not harm or non-malfeasance. standards at the front of any medical or surgical care. Then what comes is justice for the injured of the patients who have been affected by a specific type of complication. So when we see the comparison of high income and low income countries, it shows that complication is very high in the low income countries, but safety should not be dependent on geography or belongingness to a certain locality. And transparency in learning from the adverse events to mitigate future possible complications, and surgical education also has its own ethical imperative when we come to the complication. So when we approach the complication, it should not be in blamefacy of individuals, but it has to be in a systems approach. We have to focus on processes, structures, and culture of practice. For example, one of the factors that Professor Cody raised is the moral of hierarchy in the crisis management and complications. So this is a culture where we have to mitigate, we have to build, and we have to get into our teamwork environment. And we have to use standardization and redundancy as well as feedback protocols derived from different industries and aviation practices, as it gives us the foundation for the protocol, the WHO safety checklist protocol, and which has resulted in a major but cost-effective prevention of complication. So apart from the systems approach, surgical care is not a one-stop process. It is a continuum. So to prevent complications, we have to start from the pre-operative engagement of the patient until the post-operative and follow-up protocols. So proactively, we have to identify the risks and optimize the patient and enter into the rehabilitation science. And in the intraoperative conditions, so the human factors or the cognitive load, the teamwork, and the non-technical surgical skills matter most. And a post-operative surveillance and early rescue of patients for preventable mortality, and as well as improving the leadership in data monitoring, as well as the ethics of handling of complication, has to be just integrated in our surgical care. So surgical care is a continuum of process, not a one-stop process. So evidence showed that these non-technical surgical skills are very important for the surgical team, for the nurses, the surgical technologists, the anesthesiologists, and also the doctors, and then physician anesthetists as well. So the situation awareness that overlooked challenges has resulted in higher intraoperative incidents while there is a major bleeding. If you continue like operating or doing some stuff without stopping the bleeding, so that will lead us in higher intraoperative incidents like major organ injury or mortality even on the bed. So whenever there is a low score in the decision-making category of the non-technical skills, it shows that 5% risk of having a mortality or a major evidence. And communication and teamwork gaps results in up to 80% of surgical errors. And in the leadership military dips linked to errors under pressure usually. This is showed in high trauma environments of like military practices of medicine, which leads to a significant number of complications. So in the preoperative area, we are going to engage with the patients, and also we have to prioritize the patients into different risk categories, and we will use different systematic risk assessment tools like the ASA score for the, for example, anesthesiologists, like they will determine the early complication or the 30-day mortality rate, or the functional status score like the Karnofsky scale, and also the ECOG status, and so on. And at most, surgical patients could be at heightened risk of developing thromboembolic complications. So VT scores like Caprini score and Wells score will help to identify these patients and mitigate early before they develop the complications. And we have to, as much as possible, engage in a multidisciplinary input of critical care, and we have to avoid last-minute decision of, making decision. So at times, even if we have to cancel the procedure, we have to cancel that procedure. It doesn't mean like denying the patient for access to surgery, but sometimes it means giving the patient another chance or another opportunity to live longer. So in the operative optimization of these patients in the preoperative phase is one of the major emerging sciences. That is the prehabilitation science, where we have to treat any possible underlying risk factors for complications. Like most commonly, cancer patients, most commonly they present with anemia, malnutrition, and infection. So we have to give time to treat these underlying risk factors, which can lead to major complications and incidents. And we need to optimize also chronic disease like obesity, if possible, diabetes, hypertension, and other related conditions. And the most emerging and most effective science that is practiced nowadays is the rehabilitation science. This can be happened in the outpatient or in the efficient environment. And whenever possible, we have to define also a clear referral and delay pathways to the care of these patients. Whenever there is no the adequate expertise and the professional in the facility, so we need to define the referral and the delay pathways to the care. So after all, informed consent is one key strategy in the mitigating the patients and also avoiding certain complications. So it has to be open, and it should be progressed in a process. So we should see informed consent beyond being a signature. So we need to discuss risks and alternatives in an open manner, but this time also respecting the autonomy in the cultural context of our clients. And on the litigation aspect, informed consent will also stand for us to document everything and defend whenever a major complication happens that is not related to the expertise or the professional caliber of the surgical care provider. So one of the mechanisms which is introduced by the aviation science is pre-procedural checklists. Pre-procedural checklists. One of it is WHO checklist, and the other one which the surgical science recently introduced is the 𝐸RAS checklist to optimize and monitor the patient for a better and improved outcome. So we have to monitor and confirm the investigation so that no patient with major underlying conditions like anemia and so on could be skipped, or patients with like high blood sugar or renal failure go unchecked into the operating room. And we need to check also the availability of blood whenever we're undertaking a major surgical procedure. I think any one of the surgical care providers, especially in developing world, we might see like taking a major surgical procedure into the OR, then without checking blood, then at the middle of the operation, you would have bleeding, then you search blood, no blood, so no way to come out of this kind of vicious circle. So whenever possible, antibiotic and also VT prophylaxis has to be also planned and checked. So after all, there is one famous saying by the Stephen King, is a non-professor, and he puts the 6 P's in project management. So proper planning and preparation prevents poor performance. So if we take the patient without planning or preparation, and if at all you are a heroic surgeon, but at the end of the day, if certain complications happens, that is taken or deemed that to be your failure. So after this phase, we have to go into the intraoperative safety culture. So here comes the major and the rate limiting step. Whenever like major catastrophe happens, major bleeding happens, major kind of intraoperative hypotension happens, difficulty or happens here. So at this time, teamwork, human factor, and utmost the non-technical surgical skills come into play. So there should be flattened hierarchy during critical moments. So a surgeon or the one who presumed to be assume him to be the leader of that team or the crew has to might just reach the hierarchy of bringing something. He might help the anesthesiologist. He might help the nurse. He might go somewhere to bring something. Everyone here is at a critical moment. So at this time, maybe there might be play of third and fast rules. Hierarchy might not work here. It is a critical moment. So this time, everyone might have a defined role and activity to bring and the patient alive out of that operating table. So we need to have a shared mental model among the team members and leadership, especially psychologically. A stable leadership sets the tone for safety whenever a major blowout the outer, a major bleeding coming out. So if the crew member shakes and if they are not stable, so that will create a vicious circle. The patient will be dead or major complication might happen on the table. So interoperative safety structure, culture, or keeping heightened psychological safety and calming, taking seconds for alternative decision will be the ultimate savior. So the other option is using the WHO surgical safety checklist. There is well-documented complications across the world as well as in our country. So some complications happen due to just negligence of not marking, not using the WHO surgical checklist. So you might amputate the inappropriate leg. You might just do inappropriate mastectomy. You might do cholecystectomy for the thyroidectomy patient, and so on. So the WHO surgical safety checklist, once in one study stated that it has reduced the mortality or complication rate by 40%. It is just a low cost but high impact intervention to surgical safety. And team communication and briefing is also one of the intraoperative safety culture. So whenever there is catastrophe, we have to clearly assign roles to individuals so that there will not be two individuals running for the same thing, three individuals running for the same thing. And whenever you are looking for one critical moment, so there will be no one in the room. So you have to assign and you have to be the leader whenever there is happening this kind of complications. And at the end of this complication, there should be a debriefing to enable learning. And this is at times in the developed world comes through an immersive learning or simulation experience rather than on the actual patient, because it will be a lifesaver. And in the immersive technology or simulation technique, you don't have a life to lose, but it is just a scenario, a simulation that will teach you. So Charles Mayer, one of the son of, he's ultimately the surgeon later on, the son of the founder of the Mayo Clinic in Rochester, Minnesota. Now, there's a famous center or a famous hospital said that the most important result in any surgical operation is to bring the patient alive. So whenever everything happens, our major role, our major mission will be to bring the ship alive out of any kind of like havoc or serious. So coming to the common preventable complications. So there are different types of common preventable complications which could be graded according to different resources. But so far, surgical site infection is deemed to be the common surgical complication, and hemorrhage, the other anesthesia-related events, venous thromboembolism, sepsis, and also failure to rescue. Maybe this might be new for some of us, but it is one of the major complications. So surgical site infection, everywhere you go, the researchers, the papers, and the magazines, the topics, everyone could say surgical site infection, are still, since the time of the Samuel Lewis, who introduces the antisepsis, although Joseph Lister was the father of antiseptic surgery, surgical site infection has been there since antiquity. But still, it is a major problem, a major complication, even with the advent of major and modern antiseptic techniques. So it accounts to 5% of the surgical complications, but can range up to 20% in high-risk abdominal procedures. And it is a major contributor to prolonged stay and cost of patients, and it is strongly linked to system-level practices. System-level practices, and it is one of the surgical metrics in safety surgery. And prevention requires usually a bundled approach. The mere introduction of an alcohol-based or an iodine-based scrub might not prevent surgical site infection. It has to be bundled with this surgical antisepsis, antibiotic prophylaxis, the patient status, and also the surgical handling. So antibiotics has to be given at all times whenever it is imperative. So correct dose, correct drug, and timing has to be put in place. So we have to administer, depending on the time of the antibiotics, within 60 minutes of incision or 2 hours of incision whenever it is for vancomycin or depending on the type of the medication. And we need to avoid any unnecessary prolonged courses, because antimicrobial resistance is one of the 10 emerging global concerns as put forward by the United Nations. This is just contributing to the AMR risk globally and also locally. And system level reminders will improve compliance. So there should be guidelines and local adapted context just to use which type of drug and which type of antibiotics, which lengths of postoperative prophylaxis as well. And also asepsis surgical techniques. So some studies demonstrated that even in the sterilized surgical equipment, there are some level of bacterial loads in certain low-income countries. So you can imagine, so you just declared that this surgical set is 100% is sterilized, but whenever a swab taken from the surgical set is positive for microbes. So apart from this, genital tissue handling by the surgeons and also other safety maneuvers like normothermia, oxygenation, and also blood sugar management also will prevent some degree of surgical site complications and infections. So one of the other major complications is hemorrhage. So this often might not in terms of like catastrophic hemorrhage, but at times hemorrhage which might need transfusion, like in cancer surgeries, accounts for up to 3% of the overall surgical complications, and it happens in 70% of critical anesthesia incidents. And it is a common attributable cause of mortality, and it is elevated in emergency cases of cancer surgeries. So whenever possible, preoperative anemia management, surgical planning, early recognition of bleeding. For example, if you just continue like taking 𝑃ₗ𝑠 and GauzeS, and then you continue operating without measuring or anticipating the level of bleeding, so that will be one of the defects or the gaps in the situational and awareness of the knots. So whenever this kind of catastrophe happens, we need to have a clear massive transfusion protocols and availability of blood. So blood safety in this management of hemorrhage as well as in prevention of infection has to be handled with safe transfusion practices and use of usually the tranexamic acid, especially in trauma patients and bleeding patients. Usually in low-income settings, tranexamic acid is used most frequently in gynecologic surgeries, especially in obstetrics. But in surgical care, it's not that much common to use, but it is the most cost-effective method whenever there is bleeding in like emergency surgery or cancer surgery. And also, we need to also audit the use of all transfusion practice. And the other major complication surgical care is anesthesia-related safety. There should be pre-anesthetic clinics. So the anesthetist or the anesthesiologist should not see the patient at the operating table or in the ward. They should see in their pre-anesthetic clinics. And if there is any rehabilitation needed or optimization needed, so they will manage and they will stratify the problem and risk associated with this patient. But in low-income settings, there are often few centers or hospitals having their own pre-anesthetic clinics. But this helps us to assess the airway and planning both in the human resource and like if they do need multidisciplinary care or if their airways are not that much difficult, medication safety and labeling in the intraoperative environment and handovering after the operation is also another critical moment. So risk stratification, especially in emergency setting, like preventing against aspiration and airway compromise in the simulation or rehearsal of this emergency catastrophes will also helpful. So the other complication, which is less noted, but patients usually found collapsed in the inpatient setting whenever the patient might be stable in that house. You might be told that the patient is gasping, he's collapsed, and he revived after CPR. But after all, if it is like massive P, so nothing will be left to do, especially in low-income settings. This is one of these major complications is the venous thromboembolism. It's usually silent without appropriate checklist and checkup, but usually fatal. And it accounts for up to 2% of postoperative complications, and out of which 50% is pulmonary thromboembolism or pulmonary embolism. So usually it is one of the main cause of silent mortality and often taken as mislabeled as myocardial infarction or cardiac arrest. But risk increases postoperatively, especially depending on the type of procedures, underlying risk factor before the surgery, and usually it's under-recognized in many settings. And instead of treatment, prevention is highly effective in forms of prophylaxis. So we need to risk stratify before the operation. Usually, simple scoring tools like Caprini score or Tadao score, different scoring systems depending on our setup. And we need to document risk status so that there will be heightened follow-up or management protocol or mitigation strategies. And we need to also reassess post-operatively for these VT risks. And usually this could be prevented in forms of mechanical methods of medication methods or pharmacological prophylaxis. So early mobilization after operation, use of stockings, and also active ambulation of this patient in the pre-op and the post-op period could be very imperative. And these days, even patients in the ICU, apart from physiotherapy, they could work with the machine using the walker and the families. So this might not be just the practice we're doing in the low-income setups, but we see in the Western setups. I think it's possible also in the low-income setups. And we have to embed this VT prophylaxis protocols in our routine orders. So the other is the post-operative surveillance. So the surgery might be a success, but the patient outcome might be futile. So you might do a very fancy procedure, but that will be meaningless if the patient is not coming out of the hospital alive. So you might talk here and there, you might be the heroic surgeon, the heroic anesthesiologist, but if the post-operative surveillance is not appropriate, so the patient might be complicated and you might automatically lose the patient. So regular monitoring and clear escalation pathways whenever there is some certain kind of complications and nursing empowerment or human resource to act is appropriate in the post-operative safety strategy. One of which is post-operative pain and safety. So as we know, pain can increase the threshold of developing myocardial infarction and other related complications like cardiovascular complications and also pulmonary complications and then overall recovery. So we might embed the ERAS pathway in this post-operative pain modality, avoiding or using opioid-sparing analgesia, and whenever there is need escalation, to escalate and appropriately manage the pain and create a pain-free hospital is also very important. So the other most common complication, especially in the emergency setting, is post-operative sepsis. Usually, it's one of the main cause of mortality, especially in abdominal operations in our setups. So it needs a time-sensitive diagnosis. So buying minutes and hours will be a game changer in the management of patients with sepsis. So we usually need to use sepsis diagnosis bundles and need to act in the sepsis surviving campaign. So before 2017, there was a 6-hour time guideline to act in the management of sepsis. Then in 20 it comes to 3 hours, and now we need to act in less than an hour. So delays are usually system related until you draw and do the blood culture and so on and so on. Apart, associated with human resource gap will lead to this sepsis to be one of the major morbidity and mortality. So failure to rescue is one of the common I could say not complication, but one of the common scenarios which is happening across hospitals in low resource setting. So it is often seen that in the morbidity and mortality reports and seminars, they will say the patient was fine and he was just ambulating, but after an hour, we found him dead on the bed. And there should be some kind of pathway, some kind of progression, some kind of trajectories for the patient to complicate in such a way. But most often, it is usually linked to failure to rescue. So this is defined usually as days following treatable post-operative complication due to delays in recognition, communication, or intervention. So this usually reflects to detection and response failure. So there will be patterns usually for the certain complications to happen. For instance, if there is abdominal complication after anastomosis, we usually trace with vital sign. Pulse rate will increase first, then the patient will be febrile, then elate, then so on and so on. There will be some kind of patterns. But whenever there is failure to rescue, there will not be detection of these patterns by the care providers. This could be due to a delay in the recognition or a communication failure or the intervention. This is one of the key quality metric, and it accounts up to 13% of the problems in low-income setups, and usually this happens in the ICU setups. So human factors in surgery most nicely explained and presented by Professor Cody. So humans with fatigue, stress, and cognitive overload can underperform. That's pretty clear. So a surgeon who is fatigued, a nurse who is not well compensated, and other healthcare workers as well, they will underperform, and the cognitive load will be also significant. So we need to design systems for humans, not for heroes, not for healthcare workers who can act or who can perform heroic type of cares. So we need also to learn from aviation and industries in the project management and safety culture. So usually this is one of the challenges in the resource limited settings. We have a significant workforce shortage, and since the Lancet Commission, it has been more than 10 years, and we're still at the same number, at the same metric. And the workforce is just not that much developing well. And there is also data scarcity about the progress and our monitoring of the complications. And yet, many safety practices are low cost and can be achievable even in low income setups. We have seen the WHO checklist. And to circumvent this, training and task sharing, usually in surgical care, will have a significant imperative outcome, and this has been seen in Ethiopia and Rwanda in some low resource settings that whenever there is a critical health gap, training of some caregivers will just save lives, and at times training can help to make the surgical care even more safer. And supervision, proctoring, and tele mentoring can also save many lives. So after all giving this surgical care, surgical provision, if we don't measure, if we don't audit, if we don't give feedback, so our work and our progress might not be detectable and might be futile. So we have to track complications and mortalities as well as near misses, which is one of the key implications of the recommendation by the Lancet Commission on Global Surgery. And we need to use feedback loops among caregivers and among institutions. And we need to use also data for learning, but not punishment, not punishment. And there should be also morbidity and mortality conferences. So morbidity and mortality will teach us in managing the next complication or the next mortality or morbidity. So they will have a significant resource. So there should be a structured and blame-free analysis, and rather than pointing on the individual, we have to focus on the system and take actionable recommendations and activities. And after surgical complication happens, we need to have transparency and disclosure, because the the attendant or the patient has the right to know what type of complication happened to them. There should be honest communication to your trust, and we need to also support the clinicians after adverse events. We shouldn't like belittle, replay, and talk behind the backs. Instead, we might give feedbacks and also supportive structures. So the patient has to be at the center of any surgical care. So we need to encourage the patient since the start of the surgical planning, after to the discharge and even to the follow-up. So encourage them to question, to engage in decision making, and also in choosing alternatives. So the take-home message is that most surgical harm is preventable. 50% of the surgical harm is preventable according to resources with the existing knowledge and with very cost-effective NDZ safety protocols. And safety has to be a system property. It should not be privileged to certain geographies, certain patients, but has to be to all patients and at all times. And we have to measure, learn, and improve our surgical care. And safe surgery is possible, and equitable surgery is whenever the surgery is safe. So these are the differences, and safe surgery is
Thank you so much for the insightful presentations. Thank you everyone for participating. We sincerely appreciate your time. I see that we do have a couple of questions in the chat box, and we will be starting our Q&A session, which will be moderated by Mahmoud Balouch. You can also ask your questions during the Q&A session, and we will try to address as many questions as possible.
Thank you, Dr. Nebiyou and Professor Josephine William Cody for the insightful and valuable presentations and session. So welcome everyone to the question and answer session. Today we had the privilege of exploring two critical dimensions of surgical practice. First is the human factor, and the second is teamwork. So that are the safeguard of operation room and the practical strategies by Dr. Nebiyou that prevent complication in the surgical setup. So this session remind us that the excellency in surgery is not defined by the technical skill alone, but the collaborations, vigilance, and a shared commitment to the patient safety. So with this foundation, we are now opening the floor to the questions. moving toward the chat box. But before moving to the chat box, I'm just talking about human factor in the operating rooms. We are really focusing on the non-technical elements that influence safety and performance. These include WHO surgical safety checklist, 𝑠PAR communication, teamwork, leaderships, situation awareness, and scene making under pressure. So I would like to ask Professor Cody, could you please share for our audience a practical example of how improved communications or collaboration among surgical staff has directly enhanced patient safety outcome?
One more question. What was that question again? I didn't know that you were aiming it towards me.
Could you please share with our audience that how a practical example? I just want a practical example from your side. How improved communication or collaboration among surgical staff has directly enhanced patient safety outcome.
So you know that there are three steps to surgical procedures. There's a perioperative phase, which is the pre-op, intra-op, and post-op. To continue improvement in the operating room, it takes a whole team. Again, when I was speaking about skill set, all of that is all great. Everybody has their own skill to dedicate towards the patient care. But mind you, all eyes are open. I mean, all eyes are there in our peripheral vision everywhere to make sure aseptic technique is golden. So to assure that everything is in alignment, it starts at the beginning at the front desk when you find out what type of procedure that you're doing. The doctor knows what we're going to be doing. There's a preference card that we go by that we are sure that everything that is inside of that preference case card, we are sure that what we have to do is ready and prepared. We provide that sterile feel for the patient, for the doctor. We anticipate anything that happens with anyone walking in between our two sterile areas. It's so important and paramount that we follow the steps of aseptic technique, surgical conscience, and anticipation of the surgeon's needs, and not just, again, of our skill set. It's what we know as a human being, of feelings of what we know is wrong versus not speaking out, which we should. So to prevent these SSIs, like the doctor was saying, these are all preventatives. Is your ESUs on? I mean, are you using your Bovie pad? Is that on? We see things. We have to watch what the circulating nurse does. We watch whether or not make sure the anesthesiologist mask is up. All of those are very simple things to do, but they are so important to the patient because we have these SSIs. You don't know what might happen. You want to make sure that you can hear the HEPA filters filtering the air throughout the room. You want to make sure that you have that positive pressure of air in the room. You want to make sure no one comes in according to a procedure that you're doing in the OR. Everybody is vigilant. If I walk into a OR and you're doing a total, everybody's going to like, huh? Because you're not supposed to go into a room where we're doing a total hip or total anything with ortho and bone cement. So when we know that particular items are used during a surgical procedures, me as a tech, I have to make sure that one, anybody pregnant, especially when I know whether or not, we're going to be using bone cement, it's toxic. So we're all vigilant. We're all human. We all speak out. Again, most of those errors begin in silence. So safety begins with voice. You can't come in scared. A surgeon is a human being, but, they want you to be the second pair of eyes for them. They ask for something, you give them what he said. Don't give me what I asked for. You give me what I need. So that's how punctual we must be in the operating room. Someone goes in there without a mask on, we'll run them back out. So you have to be vigilant in order to be able to prevent any type of errors that happen into the operating room. I'm a very passionate person when it comes down to training students the right way. You're going to get those that are a little bit upset with you because you're being too hard, but you just don't understand where you're going. And once you realize where you're going, you're going to thank me later. And I do get that years later. You did this to me, and I appreciate you training me the right way to be prepared for the safety of the patient. I apologize for taking so long. I'm just a chatty patty when it comes to safety of the patient in the operating room and being very aseptically sound.
Thank you, Professor Cody. So
Okay.
there is another question from our audience. She wanna ask, in low resources or post-conflict setting, what practical strategies can operating room team implement to improve patient safety and efficiency without major financial investment?
Great question. So because in low resource or post-conflict environments, most harm is not caused by lack of equipment. It's caused by communication breakdown, unpredictability, and system chaos. So the biggest safety gains from behavior and organization, not the money. So again, like the doctor was saying about the high impact, no cost for safer surgeries, you've got your standardized communication that takes 5 minutes to save lives. You know, you've got your timeout. I think someone has a question for him in reference to timeout and understanding that it is so important to be able to implement that. Every part of the procedure or the surgical room or the time that we have that patient are steps to everything. Every particular person in the room as a team is a step for a betterment of the patient. So again, it's before the patient, before the incision, before leaving the room. He talked about the flattened hierarchy. Strong and silence is dangerous. So we must see something, you say something, right? Then you've got your paper checklist. He mentioned that as well. Beat missing technology. You know your skill, your precision is there, but are you recognizing what could possibly happen if you don't say something that could cause a patient to pass away? Okay, making sure that like he said, the deep vein thrombosis, you want to prevent all of that. Instrument and supplies, we check instruments prior to passing to the surgeon. So sometimes it doesn't have anything to do with your resources, but the bottom line is reliability teams or reliable teams outperform advanced hospitals. Safety comes from habits and not hardware. So take that into consideration, that it's all about what you know, how you respond to a given situation, and just act as if that's your family member there. Then everything will kick in for real. Let me just make sure that they're okay. But this is how we're supposed to treat everyone that's on that bed. Thank you for that question.
Thank you, thank you. So moving forward to Dr. Nebiyou. Doctor, you have actually two questions from our audience. So first is that who should be the responsible for WHO surgical checklist? I mean, who will fill that list? And another is that how can hospital ensure accountability among the surgical team?
Okay, thank you very much. Thank you for the next question. Usually this is yes, a point of debate, but it can be taken as context according to the hospitals and the settings. But if you ask me my belief, and also according to the safety protocols, the WHO checklist is not owned by an individual. It is a team's responsibility, that team's responsibility. So the responsibility will be to the entire team, not only to the surgeon, not the scrub nurse, not the technologist, not the anesthesiologist. And oftentimes it usually be filled by the runner or the running nurse or the assisting nurse usually, because the other will be scribing and also they might be just with the patient. So most often that might be the free person to fill in the checkboxes of the tool. But at oftentimes one of the major drawbacks is that there is a deep kind of ritualization without any kind of engagement. So the individual might be just reading the tick boxes, so the surgeon might be doing some other stuff, and also they might just fill or tick the boxes without any kind of engagement, without any kind of risk consideration. So this might just be the breach of the checklist. So the checklist is there to serve its own purpose. That is safe surgery in its part. We couldn't say that the checklist will remove 100% complication rate or mortality to the patient, but at least it will prevent preventable complications. So it's kind of building a culture rather than upholding a single individual or somebody to the misdeeds. It is a culture by the team and by the surgical care provider that the checklist, for example, for instance, if you go to the aviation industry without the checklist, without the pre-flight checklist, I haven't encountered any flight going on. Even with this pre-flight checklists, we could see some kind of aerial mismaneuvers or crashes. So it is often frequent, especially nowadays. And by the same token, the WHO checklist will not 100% remove the risk, but it will reduce the risk of mortality and complication. And it is usually by building a culture of practice and monitoring of the WHO checklist. For example, oftentimes we see how much of the papers, if you see the articles written there, how much of the papers are filled or not, but we might see in segments how much of the sign-in phase, the timeout phase, the sign-out phase is filled. So how much is that related or associated with the complication? So if you just present this kind of feedbacks and conferences to in the hospital, in the quality improvement setting, if we put monitoring protocol, so that might improve the surgical checklist. But at times, you might see the WHO checklist is used 100% of the times. But still, you might see that the complication, which should not be passed if the WHO checklist is appropriately used, if it has been appropriately used. For example, marking. If you mark on the WHO checklist, there is a thing, it's the surgical site market. So if you say yes, the surgical site should have been marked. But if you operate on the inappropriate site, if you amputate the healthy leg for the sake of the ill leg, so that shows a breach, an open breach. So that's the problem. It's not only using, but using appropriately has to be the practice. So ritualization of ticking the boxes without any engagement among the teams. The surgeon might be just scrubbing and doing some stuff without listening, and also the other also team members. So that could not be just, it will be only numbers, and numbers by itself without context cannot serve safe surgery. Thank you.
Thank you so much
Thank
for
you,
the
Dr.
insightful and in-depth responses. I'm sorry, Mahmoud. Thank you for moderating the Q&A session. I see that we are unfortunately out of time. We wish that we could take more questions, but in the interest of time, we will now move to our closing remarks. Thank you, everyone, for your participation, and we sincerely appreciate your support.
Hey, good morning, good evening, and good afternoon, everyone. So my name is Dr. Ian Sute from Nairobi, Kenya, and I will be doing the closing remarks. So On behalf of the Operating Room Global, I would like to sincerely thank our speakers for their valuable insights and our participants for joining us from across different countries, time zones, and professional backgrounds. We recognize that many of you are participating despite busy clinical schedules, varying internet access, and language differences. We truly appreciate your commitment to learning and to improving surgical and perioperative care in your local settings. Please feel free to share key lessons from today's session with your teams, institutions, and professional networks as part of strengthening safe and effective practice globally. We encourage you to stay connected with TORG through our upcoming webinars, training programs, and research activities, which are published on our website and across our platforms. So also to receive your TORG accredited training certificate, please do note the following. So immediately after this session, the evaluation and certification form will open in your browser automatically and it will remain active for 24 hours. Certificates are issued within 5 to 7 working days after successful submission. So the evaluation is mandatory for accreditation and certificates are linked to your TORG membership ID. Once again, thank you for being part of the TORG global community. We wish you a safe, productive day or evening ahead, wherever you're joining from. Thank you once again for joining us, and we look forward to supporting your continued professional development with the Operating Room Global. Thank you.